2 part pulmonary drugs lecture. This is Phyllis Dumont. Corticosteroids are an important cornerstone to the control of inflammation in the lungs. And corticosteroids by the inhalation route have little impact on the HPA axis. However, high-dose inhaled steroids may inhibit growth, so monitor growth in children. Remember, uncontrolled asthma also inhibits growth, though. Inhaled corticosteroids, sometimes called steroids, glucocorticosteroids, corticosteroids, suppress airway inflammation by activating anti-inflammatory genes, by switching off inflammatory gene expression, and inhibiting inflammatory cells. Inhaled corticosteroids are contraindicated in acute bronchospasm. The prototypes of inhaled corticosteroids include beclomethasone, brand name Qvar in an MDA form, Becanase in a nasal spray form, and studies have shown that less than 5% of the steroid from this medication reaches systemic circulation. Budesonide or Pulmicort, 10% of the active ingredient reaches systemic circulation, and fluticasone or Flovent MDI or Flonase when it's used in the nose, 30% reaches systemic circulation. Other agents, mast cell stabilizers, the prototype is cromolyn sodium, Intol, prevents mast cell degranulation, thereby preventing release of histamine and slow-release reacting substance of anaphylaxis. Also prevents the release of leukotrienes and inhibits eosinophil chemotaxis. It won't reverse bronchospasm, the effects of histamine, or the effects of vasoconstriction. And premedicating with an inhaled beta agonist prevents cromolyn-induced bronchospasm. It does have a bitter taste, little to no systemic absorption, no significant interaction. It takes 2 to 6 weeks to see results. It can be used in patients 5 years and older. It comes in a 20 milligram ampule for use in a handheld nebulizer, QID. It's no longer available in the United States as an MDI. It's specifically helpful in cold-induced or exercise-induced bronchospasm, and the dose is 2 puffs 10 to 15 minutes before exposure. And again, it may be preceded by a beta agonist to keep the lungs well expanded. Treatment principles of asthma. The management strategy for asthma is based on an assessment of the severity of asthma, and asthma is graded from mild intermittent through mild persistent, moderate persistent, and severe persistent asthma. So a stepwise approach is recommended. If control is not maintained, it's always important first to reevaluate for compliance and administration factors. If appropriate, if you can confirm that they're administering the medication correctly and using their inhalers correctly and using them in the way in which they were ordered, and they are not at the level of control that you want, then you can go to the next higher step in the protocol. Likewise, a graded step down in treatment can be considered every 1 to 6 months if the patient is in satisfactory control and may no longer need all of the medicines to maintain that control. Step 1 in controlled asthma is solely the use of a rescue inhaler for PRN use for wheezing and no daily medication. Step 2, controlled to partially controlled asthma, would be a short-acting beta agonist as needed with the addition of low-dose inhaled corticosteroid or cromolyn or montelukast or theophylline. Step 3, or partially controlled asthma, is the same as step 2, and you can use a low-dose inhaled corticosteroid plus LABA or a leukotriene receptor agonist or theophylline or a medium-dose inhaled corticosteroid. This slide outlines further steps in increasing the amount of medication that is prescribed for a patient who continues to have symptoms despite adequate dosing, use, and correct use of their medications. It should be noted that at about step 4, you're probably going to be referring that patient, and so you can review the various additions here. Treatment principles for COPD. Bronchodilators are primary to symptom management. COPD, in all patients with COPD, need a short-acting bronchodilator, for instance, a SABA, or an anticholinergic agent for the PRN relief of increased dyspnea. For patients who are not on a long-acting anticholinergic agent or a combination short-acting beta agonist plus a short-acting anticholinergic, rather than either one alone, will achieve a greater acute bronchodilator effect. For patients on long-acting anticholinergic agent, a short-acting beta agonist is needed for quick relief of COPD symptoms. Again, patients on an optimal long-acting inhaled bronchodilator regimen who have persistent symptoms or repeated exacerbations need an inhaled glucocorticoid. If on a LAMA, add an inhaled glucocorticoid alone. If on a LAMA, add a combination of inhaled steroid and LAMA. Indications for consideration of early use of inhaled steroids are a history of asthma or an allergy component to their pulmonary problems. For asthma as well as COPD, influenza and pneumococcal immunizations are strongly recommended. When a patient experiences an exacerbation in COPD, we're going to increase the dose and frequency of short-acting bronchodilators, systemic corticosteroids, and antibiotics if purulent sputum develops. So the stepwise approach in the protocols is meant to assist, not to replace, clinical decision-making. If an alternative treatment is used and the response is inadequate, discontinue it and use the preferred treatment before stepping up. Xylutone is a less desirable alternative due to limited studies as adjunctive therapy and the need to monitor liver function. Theophylline requires monitoring of serum concentration levels. In step 6, before oral systemic corticoids are introduced, a trial of high-dose inhaled corticosteroids plus a long-acting beta agonist plus either a leukotriene receptor agonist, theophylline, or xylutone may be considered, although this approach has not been studied in clinical trials. Step 1, 2, and 3 preferred therapies are based on strong evidence. Step 3 alternative therapy is based on evidence A for a leukotriene receptor agonist, evidence B for theophylline, and evidence D for xylutone. Step 4 preferred therapy is based on evidence B, and alternative therapy is based on evidence B for leukotriene receptor agonist and theophylline, and evidence D for xylutone. Immunotherapy for steps 2 to 4 is based on evidence B for house dust mites and animal danders pollens, but the evidence is weak or lacking for mold and cockroaches. Evidence is strongest for immunotherapy with a single allergen. The role of allergy in asthma is greater in children than in adults, and clinicians who administer immunotherapy or omalizumab should be prepared and equipped to identify and treat anaphylaxis that may occur. In table form, a stepwise approach for managing asthma in youths greater or equal to 12 years of age and adults. And this is a similar table outlining asthma severity and initiating treatment in children 5 to 11 years old. Now, as far as studying these tables go, I don't expect you to memorize these tables, but you need to know that guidelines for stepwise therapy exist, and you need to have some idea of where you're going with the guideline. And you should know what to do in the early parts of the guidelines. You should realize that you would consider referrals if you were to get beyond the first several steps of one of these.